Thank you very much, Kara. So we've got about 10 minutes left, and we've seen it's a wide variety of discussion. And I would note that our mandate was to talk about payment, but everybody found the pieces that connect to one another. It's really hard to focus on payment exclusively without going back to, and in their conversation, I think Mandy, with help from Tim, got some really, they sort of identified kind of four basic components. They talked about if you want to pay for whole person health, this notion of getting the payments right, working on infrastructure, the basic elements that are there, the process redesign, and including the teams that Asaf was talking about, the process, the idea of process redesign. How do you, when you have the teams, how do you retrain them? And then measures, what Kara was talking about at the end. And I think what all these presentations show us is you can start with a focus on payment, but you've got to think about these other things at the same time. And so I guess I want to start, I guess, with Nathan and your experience. What I'm going to bring up something that you talked about, what Medicaid was working on. How much more effective do you think your programs would have been if you could get other payers to work with you? I'm focusing on the issue of multi-payer alignment, and in particular, when in your work on health equity, is it how much faster would you progress if you could get some of your commercial payers and some of your Med Advantage payers, Medicare Advantage, lined up with you as you're doing this work?
It's a great question. I don't know how to quantify the speed specifically, but I do believe that there's opportunity to move faster if there was better alignment, because that would incentivize the whole system, instead of when you start with Medicaid covering about a quarter to a third of the system, depending on where you're at. And so I think we would be able to see, particularly if we're all moving towards specific goals, like previous presentations have talked about, around addressing specific, racial and other health inequities, addressing specific opportunities like, early childhood literacy or things like that. I think you would see a lot quicker uptake versus having to wait for it to start with the payers that serve Medicaid patients, and then they use that to just go across the board for, how I've seen it play out in my practices is your healthcare system is really serving Medicaid patients, then your system will try to adjust everything towards what Medicaid pays. If that's not necessarily a priority, then there'll be less urgency around any changes that Medicaid is proposing. And so I do think there's a lot of opportunity in collaboration there. And the hope is, like Kara talked about at the end, framing it through COVID-19, saying, look, we all saw the impact across our society of these inequities. We should all be invested in moving, towards addressing these gaps.
All right, thank you. And then, Asaf, I want to draw on your unique position, because you do work internationally as well. It seems like one thing that these international systems have going for them is this notion of some sort of a global budget on a per capita basis or by jurisdiction. And that allows for that investment social services. We've had two references now to Betsy Bradley and Lauren Taylor's work, at least that I count. Do you, maybe this is a little bit too grandiose, but how much progress can we make on these issues in the US before we take on the notion of an overall budget for healthcare? Is that the elephant in the room that we just got to take on?
Chris, an overall budget for healthcare or for health creation?
Oh, I'll reveal my biases. I think you need a budget.
Well, gosh, okay. So in 40 seconds or less, yeah, I mean, most other countries in the variety of ways that they pay for healthcare, do believe in some sort of budgeting mechanism, and they don't all do it necessarily beautifully or better, but it does require the asking of the hard questions here about not just sort of letting, so fee for service often just gives you, you know, this ability to just say, well, you know, the widgets just kept widgetizing and the bills just kept on coming, and oh, the premiums expanded. Oh, what should we do? There's an intentionality perhaps at what you're getting at with global budgets, and a limited pot that says, you know, we cannot expand beyond this envelope. You know, I guess I reflect on some of the countries that I've worked in and with. So for a long time, I've done a lot of work in Costa Rica, and Costa Rica, you know, so we think, oh, it's such a different country, and you know, they have no army and they have really high levels of social spending. So what can we learn in the US? I actually think that we can learn a lot from Costa Rica, and our teams have written, and we've been in partnership a lot, because though it's a small, unusual country, you know, it wasn't always unusual. It had a fairly broken healthcare system up until the early 90s, until they made a series of pretty radical reforms that really centered on one thing that I think is, you've heard today, which is they took their, they went to a global budget, and they have a single payer system. So yes, that's an advantage, but then they did something even more radical. They forced a merger between their, essentially their VA-like, you know, single clinical delivery payer system and their Ministry of Health that was putatively responsible for public health and community health functions. They forced the merger. They said, we want one entity that's responsible for health. Here's your budget. We're going to increase it. We're going to increase it with specific focus on community and rural health and with equity. We're going to divide everyone into 104 areas where you're all impaneled to a community health team that has a doctor, a nurse, a community healthcare worker, basically a person collecting data, and a pharmacist. And then we're going to be super transparent about how funds flow and how performance goes. And for those health areas that are at the bottom of performance, we're not going to punish you like in old pay for performance schemes. We are going to look at the management and we're going to look at what's not working. But given that most of the health areas that were underperforming were also the poorest areas, or the areas with highest numbers of indigenous communities, they sent more funds to those areas to do more investment in the critical health needs. And so basically you have these blended community health teams that do, on some days, some curative and vaccination work and diabetes management, but on other days are really focusing on what we are right now artificially bifurcating as social determinants work. And I think that explains 30 years later their incredible success. We might want to learn from that.
Yeah. And Kara, I want to see if I can build off what Asaf was saying, but have you reflect on your well, your experiences in Delaware, and then and now working in a delivery system. And what since the release of the primary care report a couple weeks ago, which Asaf described, I would note we prioritized primary care, but we were very practical. I'm sorry, we prioritized payment, but we were very practical in what we suggested. We didn't shoot for the moon. We just said, let's acknowledge the corrosiveness of fee for service and reestablish the base, redo the default. And I have to say, it's been great to generate conversation. And where the conversation always goes is a challenge of, was this the right method? Oh, why didn't you guys on the panel go for more? Why didn't you go for broke? Capitation, was something, really, really go for it. And less so a lot about the what, less about the how. How do we get there? And this is a statement, I guess, disguised as a question, but I think the what is a lot easier than the how. The how is the tough part. we can have lots of debate. There's sort of hypothetical debates about the what, but it's the how, particularly because it gets into the realm of policy and politics and away from science. And so does that confirm with your insights in Delaware and any observations you might want to add now when you're working with a delivery system that clearly they've got the what? It's kids. There's a really powerful argument about the what's, but it's that how question that's so hard.
Yeah, I think that is where the challenge lies. We are on this journey. We've declared it loudly. We've shared it, with external audiences that we want to move beyond our walls and focus on children's health and move to value and create a payment model that incentivizes that investment. But then we come right up against the politics of now you need to invest differently. Now we need to get social dollars and schools and community resources to come together collectively in partnership. And so I think you're right. The how is the challenge. We also need to figure out a payment model that allows us to really look at the entire person, the entire child, which is not just healthcare. It's especially not for the average child who's healthy and needs their vaccinations and their routine checks. But I think we really do know right now mental health is a crisis. And yet we have not figured out how to make sure we're paying for mental health services equitably, that we're placing them in schools, that we have, a robust system in place. And so the how and getting there for me, my day-to-day is figuring out how to get internal buy-in, but also with an eye towards the political buy-in that's necessary at the state and federal level, right? And so there is a shift in a culture transformation that we're trying to embark on that is truly unique. And bringing it back to thinking about it's not just about healthcare doing it all alone. That requires a lot of engagement strategies around who are our partners, and there are about 1,000 of them. And I always think I've missed someone along the way to make a difference and make this impact.
So thank you, Nathan. We're coming to the end. I want to actually circle back to the addition you gave to my question, because Kara served it up, which is community input. No whole person health without population health, no population health without equity, no equity without addressing racism, no addressing racism without community input. So particularly on this anniversary of George Floyd's murder in his adopted home state, can you give us some examples of community engagement, community input that you're particularly proud of, that would sort of give us energy for the next couple of days?
Yeah, I'd say the program that best encapsulates that is our integrated care for high-risk pregnancies program that really sought to address the disparities we see in Minnesota, but we know exist across the country, and birth outcomes for African American and Indigenous Minnesota birthing persons and their children, by really starting with engaging the community around what a collaborative care model can look like. And so this has been in place now for about 5 years, and our African American, we call it ICHIRP model, has a community advisory board that helps determine the grantees, that helped determine the collaborative care model that includes things like doulas and community healthcare workers doing social risk factor screenings, and then connecting birthing persons or expectant persons with other persons in the community for centering type classes and courses, different resources, and navigate the students through social supports. Has different community events to get just messages out about pregnancy, about parenting, particularly around early childhood and early brain development, and has been really just a great model of ways that as DHS, we help steward the conversation around the resources, but determining things like what are the criteria for grantees is a community conversation. And we're actually now, as we're looking to scale up, and we have a budget proposal in front of our legislature that's supported by our governor to expand that, talking to community about what does quality look like to you, and so what are the metrics as we scale up that we're going to say our success looks like. How do you define that? And I think that speaks to that. A couple of different points I've heard is that we really do need to be able to shift away from it being just a straight return on investment, and that community really needs to be at the table when we're talking about what does quality look like and what does success look like, and having that conversation with our leadership in our agency, with our legislators, our governor's administration. Those are all, I think, parts of the socialization that we need to, if we really are kind of, value community-driven efforts, community-directed efforts that are co-created, and power is shared.
Power is shared. That's that's what it comes down to. Please, all you who are here, join me in thanking our panelists for this participation. You may not know it, but they also improv'd a lot on the questions. We were just letting the discussion go. So Kara, Asaf, and Nathan, thank you very much. Keisha, I think I'm handing it back to you.